Good afternoon. Thank you for joining us for our quarterly virtual council meeting. I'm Brandy Benson, Executive Director for Quality Insights Renal Network 5. Before we get started, I'd like to go over a few housekeeping items. All lines have been muted. This session is being recorded and will be posted to our website along with a copy of the slides. This usually takes about 1 week to get everything downloaded and added to our website. And please put your questions in the chat and we'll answer as many as time allows at the end of the presentation. For those of you who are new to dialysis or new to Network 5, we are Quality Insights Renal Network 5. We serve as the contractor to the Centers for Medicare and Medicaid Services, and we cover the geographic region of Virginia, West Virginia, Maryland, and DC. As the ESRD network for Region 5, we are responsible for helping dialysis providers and transplant centers provide quality care to people with ESRD. There are 18 networks like ours across the country, and depending on how long you've been in dialysis and in Network 5, you might know us as Mid-Atlantic Renal Coalition or MARC. We're also known and referred to as the Network or Network 5. We will answer to any and everything. Just engage with us. As you can see on the slide, we serve over 27,000 dialysis patients, 17% of whom are on home dialysis, and then over 20,000 transplant recipients in our network. Over 438 dialysis facilities and 14 transplant centers in our geographic region. We cover large dialysis organizations and small dialysis organizations in our area. The majority of the facilities in our network are large dialysis organizations that are run by DaVita and Fresenius. If you are new to dialysis or need a refresher on the network and the role that we play engaging with dialysis facilities, we are offering a multi-part virtual training session that is a network orientation, and it's really designed for new dialysis facility leaders or, again, those who really want a refresher. The training will cover what the network is and how we support facilities, your role as a leader in the dialysis facility versus the network's role, clearing up confusion around metrics, what's your organizational metrics, what's included in the ESRD Quality Incentive Program, and what are network-specific metrics. Reporting expectations, so that's reporting to EQRS, NHSN, and we can really help clarify what is needed and when it's due and where to report it. And then readiness and accountability, helping you remain survey ready, and ways to promote a safe, high quality environment for your patients and your staff. And finally, ways to support patients and families. So we'll cover handling grievances, support peer mentoring, and promoting patient-centered care. So Amanda, will you drop the link in the chat for anyone who is interested in signing up for this series? What you're committing to is that you're showing interest when you sign up, and then Amanda will get in touch with you to actually schedule the training sessions. I always share this slide as a reminder of the standard and the conditions for coverage that specifies CMS's expectation for dialysis facilities to cooperate with the ESRD network designated for its geographic area. In fulfilling the terms of the network's current statement of work, each facility must participate in network activities like this one and pursue network goals that I'm going to go over in just a few minutes. And during this presentation, we really hope to share some information with you to help be successful in meeting this standard. Our current statement of work that just started May 1st, well, we're several months into it now, so it started May 1st of 2025 and will go until April 30th of 2026, is divided into 3 areas. quality improvement, which has many metrics that we're working on, and I'm going to talk about in just a few minutes. Patient services, this is really the work that Renee drives with helping to resolve patient grievances and access to care issues, involuntary discharges. And then data management, this is the work being led by Allison Crittenden, and we do have some metrics related to this area for this statement of work as well. At this time, we're going to dig into our current statement of work, and I'll share progress on network goals for the measures we have data for. We're going to recognize facilities for their improvements and share best practices that you can implement in your facility to try to make improvements as well. First, I'm going to cover the measures we don't have data for yet, but we're still want to recognize facilities for their engagement in these areas. So I'll start off with BMA Crystal Springs, FMC Mercer County, and DeVita Hartford Road for their engagement with the network during the cohort 1 home dialysis project. So working with Elizabeth to really try to engage patients in moving to a home modality. Then DeVita Front Royal for their engagement with the network and sharing best practices for helping to move patients to home modalities. So let's talk about some of those home best practices. What is recommended to help increase the number of patients using home modalities is provide consistent education to in-center hemodialysis staff regarding home modalities. Allow staff members to anonymously contribute questions or hesitations regarding home dialysis that are addressed at a later time. Next, hold regular meetings with nephrologists and/or nephrology offices to discuss patients approaching the need for dialysis. Implement processes that ensure these patients have access to modality education prior to starting dialysis. Finally, provide education and hold conversations with patients one-on-one whenever possible. Avoid using technology to provide the first introduction to home dialysis concepts. Amanda has been working on a sepsis awareness and prevention project. This is really to decrease hospitalizations and use of the emergency department. We don't have Medicare claims data at this time to support the work in this area, but we are still seeing a lot of best practices that facilities are sharing with us, including physician engagement, which you're going to hear a lot about as best practices for several of the projects we're working on this performance period. Physicians are actively involved in patient and staff education, and facility infection data are reviewed monthly. Another best practice is infection prevention leadership. So one designated staff member oversees infection education, ensuring consistent messaging and alignment across the entire team. And then patient and facility engagement. So patients enjoyed World Sepsis Day. This is success that a facility had and shared with the network. So really getting patients involved in activities, and the IDF facilities in the network celebrate milestones such as 1 year BSI and access infection free with recognition events. So really celebrating the success with everyone. I want to just share some pictures and highlights of what facilities involved in this project have been doing. So DaVita Lexington participated in the Wear Pink Day. They created a vaccination bulletin board to help bring awareness for their patients. And then they also created a sepsis bulletin board. And take note of the 365 days since their last bloodstream infection. So that's great work, and really appreciate you sharing these pictures with us, DaVita Lexington. Prince Frederick was also very active in this project. They participated in the Wear Pink Day and created a Sepsis Stops With Us. Love that idea, with a bulletin board to provide awareness and education to their patients. Then we have West End Dialysis and IDF Parkview, who created sepsis awareness bulletin boards in their practices. IDF Parkview got really creative with superheroes knocking out infections, and the pictures, the heads of all of the superheroes are their staff members. So a really creative way to promote this subject and bring awareness to infection prevention. Okay, now moving on to the measures, we do have data to support our work, and I'm going to start with transplant. You might remember that we have two measures in this area that we're working towards: increasing the number of patients on the transplant wait list, and then the number of transplants that patients receive. So actually getting kidneys into patients. So this first measure over here on the left, you'll remember seeing the bar charts for these measures. On the left-hand side, the dark blue bar is baseline. The royal blue bar in the middle is our progress, the network as a whole. So progress we're making towards the goal, which is the lime green bar. That is the goal that CMS set for our network. And so for waitlisting, we are well on our way of achieving this goal, an area that Network 5 typically really performs very well in. So feel very confident about meeting the waitlisting goal for this performance period. Over here on transplants, we're not tracking exactly where we would like to be. This is a very aggressive goal. Always great to see we're making progress year over year, but the goal gets bigger year after year. So this one is more of a challenge for Network 5, but please continue to keep up your work and your efforts in this area. Some facilities that I'd like to recognize for their work in transplant is Southampton Dialysis. Is a facility that I worked with one-on-one, and over our time of working together, which was 10 weeks, they added 3 patients to the wait list, which is really great work. And the facility attributes their success to getting the entire team involved, not one person owning this task and this dedication to transplant. Everyone in the facility was talking about transplant. So again, really getting the entire team involved and getting their physicians involved. So physicians were talking about transplant during rounding. So great work, Southampton Dialysis. This was really fun to work with you on this project, and I'm so pleased to see your outcomes. Also doing great things in transplant are DaVita Renal Care of Lanham. They've had 7 patients receive a transplant since May 1st. That is incredible work. Some facilities don't have 7 patients receive a transplant in 2 years. So this is a great work for a short period of time. FMC of Charlestown had 4 patients receive a transplant since May 1st. Alexandria Kidney Center also had 7 patients receive a transplant since May 1st. Really, really incredible work. And then RAI Mercury Boulevard, Hampton, had 6 patients receive a transplant since May 1st. I wish we were all together and we could give these facilities a round of applause. This is really incredible work. DaVita Kidney Home Center PD, they added 11 patients to the wait list since May 1st. And then US Renal Care Fairfax added 9 patients to their wait list since May 1st. So this is proof that this can be done. Please continue working in this area. We do have some best practices to share that these facilities implemented and helped reach the success that they are experiencing. So act as a case manager. Patients do need to demonstrate an interest and motivation when pursuing transplant. However, their ability to understand the steps and execute can be limited by a number of factors. So your help is needed to help them through the process. Continue monitoring the patient's status even after they've been added to the wait list. When patients are moved to an inactive status, they continue to accrue time, but they cannot receive offers. One of the leading reasons for patients being made inactive is candidate workup incomplete. Again, acting as a case manager will help with this. Patients may not understand what the status change means or what steps are needed to move back to a status that allows them to receive offers. Your company's internal system may have a way to monitor a patient's status, or you can check the transplant waitlist report available in EQRS. Reach out to Elizabeth at the network if you have any questions about any of these best practices. Finally, learn about medically complicated kidneys and delayed graft function. I'm going to share some information about a webinar series that's going to help with this. And again, if the expectation or the desire is really that you at the dialysis facility have a general working knowledge of these terms and you help patients feel more confident and prepared. So not to be experts about kidney transplant, but have a general working knowledge to help patients be familiar with these things and feel comfortable when the transplant center provides more information. Okay, so as I gave you a highlight, a preview in the previous slide, but we do have a transplant educational series that is going to start in December. The theme of the series is Bridging Dialysis to Transplant, Education for Facility Staff. Each month for 5 months, we will cover a new topic. We're going to start with the psychosocial considerations in kidney transplant. In January, we're going to cover understanding kidney transplant listing and allocation. In February, living donation. March 18th, I thought I updated that slide. We do have a date now. It's March 18th, 2027, excuse me, 2026. We're going to cover the evolving landscape of transplant and then close out the series in April, covering nutrition for dialysis patients before and after kidney transplant. All of these webinars will be free. We are applying for continuing education credits for social workers, nurses. We will also apply for dietitians for the April webinar. Application of CEs does not necessarily guarantee CEs, but we are going to go through the process and try to offer those CEs for all of the webinars, again, for free. And registration materials will be available next month in November so that you can start registering for these events. Okay, moving on to vaccinations. Again, we have 2 measures in this area focused on vaccinations for patients. The first one is pneumococcal pneumonia, really wanting to see patients up to date with their vaccinations. And as of September 30th, we have reached this goal, but we can backslide depending on your performance and keeping those patients up to date with their vaccines. So great work in this area. Amanda leads the work with vaccinations and has been working with a really engaged cohort that I'm going to talk about in just a minute. But the second vaccination goal is influenza. At the time that this data was pulled, influenza season was just starting. So this is about a 2% of patients have been vaccinated. But of course, we do expect this rate to go up pretty significantly, ultimately to reach or exceed the goal of 80%. So I have lots of facilities to recognize for their work in vaccinations, and I want to start off with IDF Chestnut Square. This is a facility, again, that I've been working with one-on-one, and over so far we've worked together for 10 weeks. We've got another check-in on Monday, our final check-in, but this facility has vaccinated 89% of their patients already for influenza. And they attribute their success to putting a process in place, the key to quality improvement. They made a plan, they put processes in place, and they're following that. They also attribute their success to getting their nephrologist involved. So if a patient refused when the staff talked to them about getting the flu vaccine, the nephrologist immediately followed up and ultimately had success. So great work, IDF Chestnut Square. They're also planning to use a similar process to get their pneumococcal vaccines up to date, more of their patients up to date. So again, really basic principles of quality improvement that you put processes in place, and usually you can make adaptations to make the same similar improvements in other areas of care. So great work, IDF Chestnut Square. Also want to just give a shout out to the facilities working with Amanda in the vaccination quality improvement activity. You all have really demonstrated some great engagement with the project. And last week you had a deliverable due, and 86% of you got your deliverable submitted on time, even with the AWS outage that was creating all kinds of technology problems for the entire country, probably beyond the country, the entire world. So really great work. Appreciate that. The following facilities have already exceeded their pneumococcal goals and have really showed great work in this area. Holy Cross Hospital, Holy Cross Dialysis Woodmore, IDF Parkview, Fresenius Medical Care Norfolk, South Laburnum Dialysis, FMC Greater Baltimore, FMC North Salisbury, U.S. Renal Care Colonial Heights, IDF Arundel Center, U.S. Renal Care Petersburg, and BMA Charleston. Some vaccination best practices that you all can implement in your facilities to see great results also are leverage the state vaccination systems and EQRS. So verify the patient vaccine history to avoid missed opportunities and captured vaccinations that took place out of the dialysis facility. Motivate through personalized education. So use transplant readiness, infection risk reduction, and patient-specific goals to increase acceptance of vaccines. And finally, bundle your efforts. It is flu season, it is here, it is upon us, and now is the time to pair flu and pneumococcal vaccines whenever possible. Moving on to data quality. So these are the last two measures that we have data for, both working to get forms entered into EQRS timely. So the 2728 forms need to be entered into EQRS within 45 days of the patient starting dialysis. As of September 30th, we were right at goal for this measure, but this is a rolling 12 months, so it is very easy to backslide. So make sure your facility has processes in place to get these forms in on time. The next measure is the 2746, so the death notification form. You have 14 days within the patient's date of death to get these forms submitted. We have exceeded this goal at this time, but again, it's really easy to backslide because of the rolling 12-month period. If you need help with these measures, please contact Allison Crittenden at the network. She can help you and give you some ideas and guidance on how to put processes in place to meet those deadlines. At this time, I want to recognize some facilities, starting off with DaVita Garrisonville and Legacy Dialysis of Leesburg, who have shown the most improvement over this performance period in their data quality. So DaVita Garrisonville went from 67% of their forms being submitted on time to 83%. And then Legacy Dialysis of Leesburg went from 50% of their forms to 100% of their forms. So great work. Really appreciate you putting the time and effort into making these improvements. The following facilities have 100% submission rate, so getting their times submitted, getting their forms submitted in EQRS on time. Carroll County Dialysis, DaVita Harbor Park Dialysis, IDF Garrett Dialysis Center, BMA Farmville, Artificial Kidney Center of Suffolk, Samatas Dialysis of Mount Vernon, UVA Orange, UVA Amherst, US Renal Care Fairfax, and US Renal Care Petersburg. Okay, these screenshots might look familiar to you, the login page and then the landing page for your ESRD facility report. Over the past couple of months, we've gotten a lot of questions about the ESRD facility report and the network's expectation to monitor your individual facility goals monthly. Due to the delay in data delivery from CMS, the network has not been able to update the reports since April. We hope to have a full data set in the next 30 days and we'll get your reports updated. As soon as we are able to do that, that's get all of the measures in there. So we're still waiting on data for hospitalizations and home. As soon as those data sets come in, we will update your ESRD facility report. Everyone will be notified, and the expectation will remain that you put the processes back in place to check your report monthly and discuss during your QAPI meetings. Now, just because you don't have the ESRD facility report does not mean you should not be talking about network goals and how to make improvements in these areas during your QAPI meetings. So your state surveyors will still be looking for that documentation in your QAPI minutes. So please continue to work in these areas, even if the network isn't able to supply data to verify your progress. Okay, at this time, I'm going to turn things over to Renee to share some information on supporting patients. Afterwards, we will take questions, so please feel free to put any questions you have in the chat. Renee?
Thank you, Brandy. All right, I think it's always a good practice to continue to review HIPAA practices. It's always an issue that we're seeing in the news about data breaches. So, and a lot of it is just because of carelessness. So we handle patient information all the time. You handle patient information all the time. We have to be very cognizant of what we're doing with that and how we are handing it off. So HIPAA stands for the Health Insurance Portability and Accountability Act. The law went into effect in 1996. There were three main reasons for the law. The most important one being that it's safeguarding protected health information from unauthorized disclosure. So our information, our personal information about our medical care, not getting into the hands of people with evil thoughts and plans. So we have a responsibility to protect that information. One of the things that you can do is be very mindful of how you're providing information to us. Do not email any patient information to us at the network. Email is not secure for us. Fax is okay, and so is picking up the phone and talking to us. Those, or leaving us a message. We have secure lines for that. Email is just the Wild West, so that is not a safe way to do it. If you were to email to us, it requires two-factor authentication. That means I get an email telling me that there's a protected email that I have to then submit some information about, and then I will get a text or some kind of message with a code in it that I then enter into a protected network that then releases the email to me. So it's a very involved process. What I see a lot is facilities thinking it's okay to just put encrypt in the subject line, thinking that that's going to protect it. That may be something that's working for your internal email, but it definitely doesn't translate on the World Wide Web. It does not come to us in a protected format. So please do not be confused by that. And anytime you provide personal identifiable information, which is something like the patient's name or their date of birth, It becomes protected health information when it's connected to your email that includes your company name on it. It's identified a medical provider that the patient is connected to, and that makes it protected health information. So just don't email. That is the best thing that I can say about that. When I do get an email, I'm going to take you through a few steps to delete it from your system. And also, I'm going to be reporting it to CMS. So that is a requirement we have. Nobody does this on purpose. We just have to be very thoughtful about how we are communicating patient information. Always best to pick up the phone or fax it to us. Okay, we can go to the next slide. So I also wanted to talk to you about failure to place patients. These are typically, they're when patients can't get into a dialysis facility. Typically, I'm alerted to the situation when I get a call from a hospital that's got a patient that they're not able to place. And usually it is about patients that are being refused readmission to their originating facility. A lot of times it's because patients have been gone over 30 days or they're generally chronically non-adherent. They are still your patient. You may take orders out of the system, you may discharge them as lost to follow-up, but they are your patient and you have to readmit them until a legitimate event happens, like they pass away or they are admitted into another chronic facility, not a nursing home unit or a rehab unit. It's something that is a permanent placement. That's the only time that they can not be yours. Other reasons that patients aren't accepted again is because they've got a history of behavior issues. And again, that kind of comes back, that often I see is combined with the 30 days. They've been gone 30 days and we don't get along with them, so we don't want them back. That's not okay. We also hear about patients who have substance abuse issues or they're unhoused, they've got some other mental health issues. They may have medical needs, non-payment, so they don't have insurance. Sometimes physicians are refusing, and the medical director is responsible for ensuring patients aren't inappropriately discharged. So that is covered in the conditions for coverage. So all of this really should be run past the network before you refuse to readmit a patient, because there is due process that has to be followed. And just not accepting a patient isn't part of that process. So give us a call when in doubt before you decline to readmit a patient. Really, the only acceptable reasons for declining readmission is that you have a sanctioned involuntary discharge. And that means that you've gone through the process of doing an involuntary discharge packet and the network has been involved and the state has been involved in that process. Then that patient is legitimately discharged from your facility and you're not, you don't have to readmit them. Also, if there's a documented medical need, so maybe the patient goes into the hospital and comes back with a trach and you don't have staff that are skilled or trained to perform that for the patient. That is a legitimate inability to readmit because you can't provide that medical care, but it doesn't absolve you from responsibility for ensuring that that patient finds placement. So you still have to assist in finding placement for that patient. When in doubt, give us a call, but otherwise know that patients, until they're admitted to another facility, are your responsibility. Thank you.
Thank you, Renee. Appreciate you covering these tough topics and just sending some important reminders, certainly about the failure to place. So that does bring us to the end of the material that we had prepared for today. If you have any questions, I don't see any in the chat at the moment. Please, we're going to hang out here for just a minute to see if any questions come up. You can also take yourself off mute. So we're here for questions if you have any. Okay, I don't see any, so I think that is going to conclude our session for today. I hope everyone has a great day. Oops, I see the chat lighting up. Where can we get this recording? So on our website under About, so the very first tab, there's a drop down, and I believe it says recordings or meetings or webinars or something like that. That is where the recording will be, as well as a copy of the slides. So I'll also will send out a link to it in our next alert, so you can look for it there too. That's our electronic newsletter that I hope all of you are getting on a regular basis. Yeah, so it will be there by the middle of next week. You're welcome. Okay, I don't see any other questions. That's
Wait,
really
I have
oh,
one. It's not a
okay,
question. Well, it's
sure.
kind of a question. This is Michelle, from UVA Augusta and UVA Health. We're looking to do some training and education, and I've got some things from the network and other places. But do you have a recommendation for professionalism and boundaries? Because a lot of times that really is the cause for, like, the
Yeah.
starting of the cause for behavioral issues, quote unquote.
Yes, we
Mhm.
do. We also have like a huddle up series,
Yep.
and I can send that to you, Michelle. They're real quick things that you can do in huddles with your staff, that has different types of touches on professionalism and boundaries.
Great question, and love to hear that you're doing education around that with your staff. Definitely rises to the top of the reason for grievances.
Yeah, we're doing that as a program, actually, to for patient experience,
Oh, great.
to improve patient experience, and that because that's one of the ways to improve patient
Mhm.
experience and hear from people what their concerns are.
Perfect. Any other questions? Okay, appreciate your time today. Have a great afternoon, and we'll talk to you next time. Bye-bye.